Good morning, everyone. We're going to go ahead and get started. So thank you all for being here. For those who don't know me, I'm Elizabeth David. I'm the co-wellbeing leader with Zach Asher. And it's our privilege this morning to welcome a very dynamic speaker. So today we have the privilege of welcoming a physician leader whose work has not only shaped the way clinicians practice medicine at the bedside, but also how we navigate the increasingly complex digital world that surrounds modern healthcare. Dr. C.T. Lin is the Chief Medical Information Officer here at UC Health. He is responsible for over 14 hospital systems, a system of 14 hospitals and over 900 clinics. Under his leadership, UC Health has achieved some of the highest levels of national recognition in health information technology. He is a professor of medicine and board certified in clinical informatics, but those titles only scratch the surface. He is widely regarded as a visionary in reimagining how clinicians interact with technology. He leads a 24-member informatics team with a mission that speaks volumes. We improve physician and team wellness and effectiveness by building extraordinary relationships and innovative tools. That mission is woven through all his work and has made him a nationally recognized advocate for reducing needless friction in clinical practice. Dr. Lin is a gifted educator. He teaches communication workshops, design thinking seminars, and regularly publishes on the cultural, human, and psychological aspects of technology in medicine. His passions for bridging the gap between clinicians and digital tools have earned him multiple national honors, including awards for healthcare IT innovation and the title of Electronic Physician of the Year. What truly distinguishes Dr. Lin, though, isn't his technical expertise. It's the way he brings humanity back into conversations about technology with poetry and often a ukulele. He reminds us that tech tools alone don't change care, people do. And he continually challenges us to design systems that elevate clinicians rather than exhaust them, to use data thoughtfully, and to ground innovation in empathy. Please join me in welcoming a pioneer in clinical informatics, a leader who helps us practice medicine more effectively and more humanely, and someone who consistently pushes us to think more deeply about the future of healthcare. Dr. C.T. Lin.
Good morning. There's hardly anyone here. Good morning. All right, thank you. There are a few people here. So today, I want to talk about patients and bots in the electronic health record. Two related topics, one on the immediate release of test results to patients and how we might do a better job. And then secondly, about all the AI tools that are coming your way and that many of you are using already. I have no relevant disclosures other than kids who used to be cute. Our objectives: identify risks and benefits of ambient notes like a bridge in clinical care, identify risks and benefits of generative AI in healthcare, including medical education, develop a process to address patient concerns with immediate release of test results, including anticipatory guidance. Here are our subtopics: the immediate release of results we're going to cover first, then a bridge, ambient notes, in-basket, draft replies to patients, chart summarization, medical evidence, and my personal philosophy on generative AI, the thing that changes every few weeks. And so these slides are already out of date as of last night. I love this quote from E.O. Wilson: "We have created a Star Wars civilization with Stone Age emotions, medieval institutions, and godlike technology." Movies tell us that the future of medicine is awesome, and this is all we get. Some guy yelling at the computer in the corner. So in terms of immediate release of test results, so the 21st Century Cures Act from a number of years ago, specifically the information blocking rule, required that hospitals and clinics must release test results to patients immediately upon their request. This is in 2020. And the penalty for non-compliance, as one of my colleagues said, well, just pay the penalty. It's $1 million per instance as a violation of this principle of immediate release. So the question is, how are we going to deal with this? And I would say that before 2020, At UC Health, we were releasing outpatient progress notes to patients. We were not releasing inpatient or ED or operative reports, no sensitive or legal notes such as sexual assault. Test results, we were releasing all immediate routine labs. High-risk genetics were under manual release. Low-risk genetics such as factor V were immediately released. Neonatal screens and cytogenetics for fetuses were released at 4 days, pathology at 14 days, radiology, CT, MRI were released at 7, but plain films were released immediately. So those were the settings before 2020. And after 2020, almost everything, something like 95% of test results at UC Health now deliver to patients electronically immediately, with the exception of sensitive notes and high-risk genetics. And so the question is it true that patients want their data? Do they want it immediately? Won't it make them worry? What if their doctor hasn't seen it yet? What if it's abnormal? What if it's sensitive? What if it's cancer? And so that's the question. What % of patients want to see their test results immediately? And I want you to just pause for a second and think to yourself what that number might be. What fraction? Is it 50, 25%, 75%? What's the number? And the answer is, in a multi-site study of 8,000 patients, including us, part of the collaborative, 96%. 8,000 patients at Vanderbilt, UT Southwest, Beth Israel, and UC Health. 96% prefer receiving results immediately, even if not contacted yet by their clinician. 95% of patients with abnormal results still preferred after having gone through that experience of having test results delivered immediately. 8% did acknowledge that abnormal results would worry them more. And so the question is, of the 96%, great, they prefer it immediately. And then 8%, however, of that same population would worry more. And how might we do better for those patients? And the psychology underneath anxiety and worry, in collaborating with my psychology colleagues here, you can hear that threat and uncertainty and lack of control are what underlie patients' anxiety, that test results may feel life-threatening. And then the answer is to reassure that we will work together on this. The uncertainty, which is how and when we will follow up about these results, and whether you're going to tell me about the next steps, and how to decrease that uncertainty, the part about what to do and how we're going to talk next. There's bad news from the result itself, potentially, and then there's bad news from, I don't know, I wasn't given any guidance by my clinician. And then lack of control. You can tell patients that you have a choice to view this immediately or wait for us to contact you. And we do know if a fraction of patients will choose not to look in their record, and then you can actually guide them. If you're someone who's very anxious and don't understand medical terms, you might want to wait for my team to contact you and then asking what questions you have. We actually do have a patient handout that we've developed. It's at this QR code if you want to take a picture of it and then hand it out for yourself. This is a one-pager that you can actually print out in clinic and say, we're about to do a test, we're about to do a CAT scan, a biopsy. Here, read this before the test result comes in to bypass the idea that on a Friday evening, as it always is, that patients will say, well, what am I supposed to do with this, right? So anticipate the range of results, anticipate the notification process, reinforce their choice and ask for their questions upfront at the time of ordering the test. And so 30 seconds, this is courtesy of Dr. Robert Breeze, one of our neurosurgeons here, who would say, I'm ordering a test. You might see the result before me. Worst case, this could be ... This is how we would reach you. Best case, this is how we'd reach you. You have a choice. You can look immediately or wait to hear from us. What questions do you have? You can deliver that in about 30 seconds, and that will step aside from many of the concerns that will come from a late evening or weekend test result delivery. What I'd like to do is take questions at the end, so I'm going to go from topic to topic, and we're going to switch over to Abridge and ambient notes. Hand raised in the room. How many of you have tried Abridge ambient note recording in the exam room or in the inpatient side? It looks like about half, potentially half or so. Great. I'm happy to take technical, whatever questions you have at the end about using it or whether it's not working for you. The Abridge works on your smartphone, whether it's Android or iPhone. The iPhone tool is a little bit more polished based on the integration from Epic in Wisconsin. The Android tools will be substantially improving in the next couple of months. There is a setting called one-time note preferences, and then I'm going to come back to that in a second. And then if you do the recording, the way this works is you'll ask the patient, is it okay, this is my phrase, is it okay if my AI scribe writes my notes for me today? Most patients are like, oh, I've heard about this, this sounds great, fine. And you lay the phone down and it passively records your 2-person, 3-person, 4-person conversation. And then at the end, you'll hit generate note. And in about 1 minute from the time of finishing your conversation, it will, in the green highlight on the right side here, write a progress note embedded into your note writer. And then what you'll notice is that if you look in the top right, there are 3 dots with a circle. And some of you who've tried this do not realize that you have settings that you can change in Abridge. And by opening that up, you'll actually get the detail page from the Abridge tool itself. And then in there, you can look carefully. Not only does Abridge write a medical note, it also redrafts the note at the 8th grade reading level, specifically for to-dos for the patient. And that you can copy and paste right into your patient instructions. In fact, if you use the patient instructions section, you should have seen a brand new button called Abridge Instructions, and you'll hit that, and that will populate. In addition to that, if you have preferences about, I'd like bullet points in my assessment and plan as opposed to paragraph, or I'd like comprehensive summary versus a concise summary, you can adjust all of those tools inside that particular button. So look for the 3 dots. When you pop it open, it'll say linked evidence. It's not a great name. I would expect references to PubMed from there, but linked evidence takes you to the Abridge settings, and then you can redraft it. In the next several weeks, we anticipate that Abridge will send us a software upgrade that allows us to write our own prompt. And we will say, well, this looks okay, but I want this to focus a lot more on procedures. Fine, you can ask it, when you do the assessment and plan, please focus on procedural, whatever, and then you can coach it to be better output for yourself. And if you develop a prompt that you like, you can save it so that prompt is also customizing all of your future progress notes. So I'm happy to talk about more of these in a few minutes. This is the linked evidence on the left side. In fact, if you look at a progress note and go, I don't think we talked about dogs in our conversation, and you can actually highlight a word and it'll go to the part of the transcript where you and the patient will have talked about that topic. And then that way you can say, well, I actually did not. I've had that happen to me a couple of times where, did we talk about toenails? Yeah, we did. We talked about toenails right here. So the linked evidence is quite helpful there as well. And on the right side, you see the patient-friendly 8th grade summary. The outcome from our randomized controlled trial that we did in 2025 was that the intervention group, pre versus post-intervention, went from 38% burnout rate to a 20% burnout. Time in notes per appointment, it was 8.8 minutes, dropped by over 2 minutes per progress note. This, I think, is an underestimate. This is a critique of all electronic health records. The way that Epic captures utilization in the system, if you stop moving the mouse or typing on the keyboard, it stops the timer within a second of your last motion. And so it is an underestimate. Some clinicians talk about saving half an hour or an hour per evening, and the tracking software talks about 20 minutes to 30 minutes. And so I think this is an underestimate of the savings. In the control group, you'll see the burnout did not change. Time and notes changed very little. I love the quote from our surgeon. I feel like I'm more on time. I feel like I'm not leaving the clinic with a bunch of notes that are left undone. It's a huge time saver. Primary care, it's one of those, I was one of those people who's aggressively sprinting towards burnout. And then from day one of this technology, that just stopped. I actually cried in the office at the end of the day because like, oh, it's 5 o'clock, I'm done. So if you haven't tried it, I would strongly encourage you to have a look. The takeaways, the good is that it's reducing pajama time for progress notes. There's a patient visit summary at the 8th grade reading level. The note's both more detailed and more concise because it'll bring up the toenail, the thing that was like, well, fine, that's not as important as the rest of this, and it'll capture those and bring it into your note. The bad, it's best to consent the patient, even though we are a one-party recording state in Colorado. It's not legally required to do so, but I find it is a good idea to let the patient know. And then verbalize the exam findings. In the beginning, I was telling patients, "Hey, your lungs sound great," and so a bridge will write, "Lungs, quote, great." We're like, no, I wanted to be more sophisticated than that, so I would say, "Lungs are clear to auscultation and percussion," and the patient would say, "Are you talking to me? Who are you talking to?" And so now I will say both. Lungs sound clear to auscultation and percussion. In other words, your lungs are great, and we'll just move on from there. And then over the next couple of months, we anticipate that the recording will also generate pending orders, pending diagnoses, and potential billing codes suggested for you as it's going. So get on, it's going to be a wild ride. I think get on the train now and let's see what happens in the next few months. The ugly is there's an occasional hallucination. There's potentially decreased physician vigilance. I've seen that in myself. If I'm in a rush, at the end of the day, am I reading line by line every word that the tool is generating for me? I have to be careful. At one point, I did not introduce the student who was working for me. I talked about, "Eileen, tell me about what's happening with the patient." And Eileen gave this great history that she had taken from the patient. And the AI said, "Well, Eileen, the patient's sister," because I didn't introduce the people in the room. And so that's something to be careful about, because it's trying to make sense of what's happening, and you don't always give it all the clues that it needs to do a good job. Or at one point I said, "The bruise, hey, that bruise is looking a lot better." And we would say, "Somewhere on the patient's body, there's a bruise that's looking a lot, quote, a lot better." Okay, now I need to be a little bit more precise about my description. There is this concern, I think, about productive cognitive friction. And not that I'm advising that we should go back to the old days where I would take a bunch of paper charts home and dictate late into the night, but there are times when you've been struggling with a difficult patient's pathophysiology and you think, "Oh, amyloidosis," right? And that's because you've been sort of trying to craft exactly the right note, and that's part of the thinking. And if I decrease my thinking, is that going to affect what's happening, the thoughtfulness with which you're providing care? In-basket message replies. I'll just leave, I don't have an actual question here, but think about what the right answer might be here. And I'll come back to this in a minute. Online messages have increased 350% since just before the pandemic. As an organization, we used to receive about 53,000 incoming messages from patients per month back in early 2020. You see the pandemic hit and you see all of the outpatient visits plummet, the hospitalizations changed and so forth. And then over time, if you look at the magenta, it's gone from 53,000 to 183,000. And now we've sort of stabilized at 200,000 messages incoming per month. And that's about a 350% increase. And so CT Lin has yet again ruined healthcare. I'm sorry, healthcare ruined, everything ruined, right? So one idea was, how might drafting and generative AI draft a reply? So the typical primary care doctor does receive 20 to 40 online messages from patients per day. So if you imagine a full clinic day, a full hospital day, and you're done going home at 5, and then, by the way, here's 20 to 40 more messages to tackle, and that's each day. And that's typically done during pajama time. And the question is, could the AI draft a reply for you? And it sort of looks like this for the clinics that have turned it on. I think we've turned it on for about a third of our practices here. And if you're interested in doing so for both physicians and for nurses and MAs, we can turn this on for your clinic if you would just let me know. So in the incoming message, "Hey, what is mixed urogenital or skin flora?" the patient says. And this is the AI reply. And it's not bad, right? And so you have the choice as a clinician in this practice, or a nurse or an MA in this practice, to say, start with this draft or start a blank reply because I don't want to ignore all of it. And over time, these responses are improving. Here's an example that was targeted for the physician from about an oxycodone request. And the draft reply. And this was sent with no edits from the clinician. Here's another one. And I love this. Your gratitude and satisfaction with our services are more than enough for us. I think that's more gracious than most of my colleagues would write. And so this is the kind of thing that you, with very little or no editing, you could say that's pretty good, and I can get through my messages a lot more quickly than before. Here's an incident. And what do you think the AI wrote? It wrote this. And we sent this to the patient who showed up in our clinic 10 minutes later saying, I have an emergency, right? And so let's be careful. I mean, it's technically not wrong if this was a post-op neurosurgery practice, and yet it doesn't have the right context. This is primary care, right? No recent procedures and so forth. So this sort of thing, we do have to be careful. Here's another one. Love this one. Knuckle swallow in the morning. That's the entirety of the message. And you think there's no chance that the AI is going to get this right. And so the system does read the last assessment and plan note from that clinician where the discussion of swollen knuckles and rheumatoid arthritis was covered. And it was a beautiful message. And the rheumatologist in this case edited no words and sent this to the patient. Chart summarization. We are doing early testing on chart summarization. We don't have it live for very many clinicians at this point. I'm going to stop and let you read what it said about reading this patient's chart. 82 years old. So I cannot wait to get a tool like this in broad use at the organization. If you were with me on the early journey about a year ago, the early chart summaries, we would let it run on a chart. It would say, yeah, I can only read the last dozen notes or so, and they're all physical therapy, and their PT is going great. And I'm like, well, what about the acute myocardial infarction and the two knee replacements? Oh, yeah, we couldn't read that far back. And so over time, as it's able to consume more of the chart, the summaries are dramatically improving. So we're very excited that we might be able to get this into our production system by summer this year. The other thing that's happening in chart summarization is draft hospital course. And so the AI is also being targeted to be able to say, I read your 17 days of the patient's hospital course, and I'm going to draft a discharge summary for you. That could be hours per discharge summary, I think, that this tool could help with. Medical evidence. How many of you have tried open evidence? Oh, certainly more than that. Okay, it looks about 60% or so. We now have in UpToDate. How many of you have tried Expert AI inside UpToDate? Time to move over. All right, so all right. How many of you know that UpToDate is linked from inside Epic and that you can get CME credit from using it straight from Epic? And a small minority of you. All right, we have some things to talk about today. UpToDate, first of all, well, let's cover this. UpToDate is an approved AI. We also have categories of AI undergoing approval and public AI, and we want to be very careful about it. I'm going to work backwards from open evidence, which I think nationwide, the statistic is 70% of all clinicians have registered into and are using open evidence. And I want to be very careful that University of Colorado and UC Health have no business associate agreement with open evidence. So please, 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 no PHI into that search bar. And we strongly recommend if you started off using your CU Anschutz or your UC Health credentials, remove them and put your private emails in there instead, because we do not know what that company is using. There are some reports that they may be selling clinicians' data to other companies, and we want CU and UC Health data out of there. So please be careful about that, okay? So that's something I actually did myself as we wrote this policy. Doximity, most of you probably should have a Doximity dialer so that when you call patients, you can spoof your clinic phone number. And then as part of that same business agreement, we also have access to DocsGPT, which is comparable, I think, to the AI tools for medical reference. And that's undergoing approval, and we'll give you more data on that. But here on UpToDate, there's a button called now Expert AI, and all of you should have access to it. It's HIPAA compliant. We have a business associate agreement. It works from the Epic toolbar, in the very top toolbar. It'll say up to date up there. And when you click there, many of you have set this up already, but you have the opportunity to log in for yourself for free because it's a site license that we've paid for. And then from there, you're able to download up to date on your smartphone and can do expert AI searches from your smartphone. Every single one of these searches, whether it's expert AI or a standard search for a terminology, is a half an hour of CME credit. Right now, I'm running about 295 credits because that's something that I use constantly, and that's something you could do as well. Okay, and I believe the expert AI tool is comparable in performance to open evidence, and we have a business associate agreement. You're much more protected using the tool here. Okay, and this is what it looks like. So instead of searching it with 1 or 2 words, it's actually better to put an entire sentence in. And if you have it downloaded to your phone, you can turn the microphone on and say your sentence. I have a person who's 82 years old who has these 5 diseases. What do you think? And from there, it'll tell you what its assumptions are, and then it only references material written in the up-to-date textbook. So you have much more confidence that this is something that's up and up. My philosophy on generative AI. How are we doing? Doing pretty good. Hyper change. Paper charts back in the day. I've been here since 1995, so I'm sorry that I'm such a fuddy-duddy stuck in the mud, but 30 years, 31 years. Paper charts did not change for decades. Electronic records changed roughly every 5 years or so. We've been through a fair number of them here on this campus. The Epic EHR version upgrades are quarterly. I actually had a leader call me and say, well, just tell me what fraction are we done so that we can stop putting upgrades in. The answer is never. In fact, they're going to come faster and faster. And generative AI tools change weekly now that you can hear in the news. It can be unsettling. And furthermore, generative AI is available to the public. And I'm sure if you're a practicing clinician, you've had patients come in and say, well, my AI says this about you. Actually, the thing that really caught my attention was one of my colleagues was on a telehealth call with their patient who was sort of looking off screen. And then they would occasionally pipe in and say, yeah, my AI agrees with you, right? Wow, you're cross-checking your doctor as you're talking. How interesting. And so hyper change is inevitable, and I'm sorry. Those of you who've used AI to draw pictures, you be careful of the biases, right? If I say, please draw a doctor besieged by technology on all sides, it'll draw a Caucasian male doctor, and I have to tell it. Actually, I'd like it to be an Asian doctor. And then do not do this. CMIO does not recommend pasting patient PHI into public AI, specifically open evidence, that sort of thing. ChatGPT, for example, please don't do that. Or using credentials from UC Health or CU to do so. Do not blindly trust the AI output that you did not verify. The sweet spot for generative AI, I'll say this twice, the sweet spot for generative AI is when you are the expert and you can spot errors and it helps you do your work, right? Please, please be very careful. Up-to-date AI, up-to-date expert AI may be an exception, but the vast majority of these tools, if you're searching for something you don't know, you have to be super careful because it will sound completely confident, right? About a year ago, I think there are several cases nationally where lawyers were arguing in front of the judge, and then the judge went back and checked the references. All the references are made up because it sounds great. The AI is great at making references that sound exactly on topic for what you're trying to do. It's trying to please you. And furthermore, if you ask it, hey, isn't it true that blah, 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 it hears your tone and it tries to agree with you the best it can. And if you ask the exact opposite question, it'll try to agree with you the best it can. So be careful of the biases you're putting in and be careful of the hidden biases that come back at you when you use tools like this. Efficiency versus automation, complacency, fewer evening hours in terms of efficiency for writing notes, but the complacency is, like I was saying earlier, I used to think of new diagnoses when writing my note later. I'm no longer writing my note later. And if I'm losing that productive cognitive friction, if I'm no longer thinking, the AI was never thinking, who's doing the thinking? And that's something that I don't think we've answered yet, right? And then what I do recommend is it is time to dive in and play with the tools that your patients and the public are playing with, whether it's ChatGPT, Perplexity, Claude, Gemini from Google, drew this image. This is my prompt for it. Again, I had to specify some things that it had made some assumptions for. But the other tool that I didn't mention on here is Microsoft Copilot. Any of you using the tools from Copilot yet? Yes, a handful of you are. And I think that's going to get a lot better as well. CU just partnered with OpenAI, but CU also has standard Copilot that will help do some brief summarizations of emails. But if you pay for, I think it's $30 a month at this point from CU IT, separate from UC Health, you can actually get the more sophisticated tool, which will actually do facilitator for your meetings. So if you're on endless Teams meetings like I am, it'll actually summarize your minutes as you go, and it'll say at the halfway point, so far, so-and-so has talked about this, and then make sure you come to conclusion because you only have 5 minutes left, and make sure there's some action items, and it'll deliver to you a grid of topics discussed and action items. These sorts of tools are getting way more sophisticated. And so on. And also, if you have a large PDF or a large Microsoft Word document and you want it to summarize for you, it'll do that on the fly as well. So these tools are evolving. You ought to be playing around with them to keep up. I have this idea of Greek chorus. And no, I'm not thinking about Aeschylus. I am thinking about Aeschylus, but I'm misusing the term in a way. I feel like the complacency of having an AI say, this is what you should do, and then I'm going to say, I agree, right? I wanted to combat complacency by giving me different entities. Maybe I'm the captain of the ship and I have different AIs. One who's a patient advocate, one who's a quality maven, one's an F1 driver, right? Can't wait to get to the end, right? One's a wise sloth, one's an evil genius, and one is the main hero, or summaries of my actions in the last 10 years in the electronic health record. And let's say a patient says, may I have an antibiotic? And the patient advocate AI says, sure, make them happy. Right? The quality maven says, actually, antibiotics is never appropriate for sinus infection. I can give you references. And the next one is the F1 driver. You know what? Just prescribe it. You don't have time for this conversation. You're 3 patients behind. And the next one says, have them try the saline rinse. Have them call in 3 days if they're not better. And most people will be better. The evil genius says, hey, are you thinking about fungal infection? What about pneumonia? Shouldn't you be getting a chest x-ray here? And then the main hero is a summary, it looks like you only prescribe an antibiotic about 18% of the time for acute sinusitis. Maybe you should follow that guideline. So I would love to have different voices talking to me so that I have to make that choice, right? So, and then in summary, for anticipatory guidance, I think we should counsel patients at the time of ordering. For ambient notes, I encourage you to try it. And if you're having any snafus with it, I'm happy to take that in the Q&A. In-basket art, automated response technology. The AI replies are improving. Medical evidence, please take advantage of up-to-date expert AI. It is a campus license. You can use it immediately for yourself, for all of your learners. And then my speculation is hyper change is something that we're going to have to stay on top of, and it will just get faster. Discuss, adjust, and adapt. And that is my talk. Thank you very much. I would like to reserve, you know what? Maybe I'll sing my song first. Some of you may know that I sing a song at the end of some of my talks, and I have a song for you. And the tune is Sweet Caroline. So hopefully some of you actually know this tune, and I would love for you to sing with me. I'm going to give you the refrain, and I want everyone in this room at least to sing. It goes like this, under the third stanza. Chat, GPT, bum, bum, bum. You're helping doctors do their best. Well, that was not a lot of big sing-along. All right, when we get there, please help me. Here we go. When we began, I couldn't understand you, but now I know you're growing strong. I met you in winter, AI winter melted to spring. Who knew that chat would come along? Replies, message replies, notes summarized, surprising you, surprising me. Everybody, Chat GPT, bum, bum, bum. You're helping doctors do their best. We can agree, bum, 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 that your help leaves me refreshed. And now we Look at these charts. Now they don't seem so daunting. We analyze them easily. And when I'm tired, tiredness rolls off my shoulders. When you compose, I click agree. Replies, message replies, notes summarized, surprising you, surprising me. Chat GPT, bum, 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 helping doctors do their best. We can agree, bum, 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 that your help leaves me refreshed. And now I'm going home. All right, now I'm open for your questions.
All right, that was awesome. Thank you. Anyone have any questions?
Copilot to put in charts with patient-specific data? Because I asked the IT department for UC Health, and they're like, "We can't give you a good answer." Like,
yeah,
cool.
You have two different questions in that. A, recognizing that Copilot is embedded in Microsoft Excel, and that you can use it to do pivot tables and some pretty interesting analyses if you pay for the paid version of Copilot. If you're using the CU version, then it is HIPAA compliant. And if you are putting patient data in there, I would cautiously say probably yes. But that's right on the bleeding edge of what we're doing. It would be best if you can subtract the PHI out of it. 80-year-old with these conditions is much safer than, oh, I pasted the entire progress note in there with all the identifiers. Please be a little cautious about that. But if you're doing, multiple patients, and if you could subtract the PHI, you should be pretty clear there to do that. Other questions? Please.
What suggestions do you have for patients who scour their results as inpatients?
Yes. So in addition to immediate release in ambulatory, since patients sign up in ambulatory and then go off to the OR and come back to inpatient, it's something that I think you should be talking about anticipatory guidance. You're going to see test results roll in as they come up for us. Rest assured, we are looking at all of them, but boy, we have a lot more things we're doing out here than being able to come into your room all times of day and night. Please save up your questions for the next time we come in, right? And I think that's something that once you set a guideline with the patient, the vast majority, perhaps not everyone, will say, oh, I didn't know how that worked for you. And so that's something to consider. Same thing with ambulatory is patients were like, were you going to look at this? And we're like, yes, we look at 100% of these test results, and being able to anticipate that question, the ones that come up. Does that answer your question, or what flavor of that? Yeah. Other questions?
Thank you very much. Great talk. I love hearing about all of this. So as clinicians, we're here to promote health for our patients and our communities. How do we balance the adverse environmental and health impacts of AI in the data centers with the benefits of them mixed with the adverse health effects to our communities?
Can you be a bit more specific, Zach?
I think some of the energy utilization driving up energy costs for our less advantaged patients and populations, in addition to the excessive water usage for cooling data centers in a time of drought as well.
Excellent question, and you know that I don't have a great answer for it. Everyone knows that use of AI does consume lots of power and lots of water for cooling, and that in more disadvantaged parts of the country could be an adverse effect. Offsets can come from wind and solar, and also compute power is dramatically improving. Notwithstanding that we have now blocked use of DeepSeek out of China as an AI, it's also true that algorithms are getting better and less time compute intensive, right? So when we had announced a couple of years ago that NVIDIA chips would not be sold to China, they promptly came up with an algorithm that didn't need the latest AI chips and performed equally well. So I think over time, the crossing curves for, yes, the compute and the usage will increase. At the same time, our algorithm efficiency will improve. Will it balance out? I don't think it will completely, but there will be some offsets. And that's a terrific question that we don't have a great answer to. Thank you.
What are your thoughts on the next big frontiers of AI in medicine and application of AI in medicine?
I'm very concerned about the possibility of, as we were talking about, more suggestions as we link knowledge to our transactions. How much of our knowledge will be incorporated by the AI, and how much do they need me, right? I've posited the idea that there's a mini me and then there's a maxi me, and maybe I'm still the maxi me for now, but the mini me is maybe the entity that spins off, and if it can be proven to be reliable, I don't answer online messages anymore because an abstraction of myself over the last 10 years of things I've written in the record is good enough to handle incoming questions from patients at home. At what point is that the right balance? And then also the concern I have is about the humanity of humans interacting with humans, right? If we're all interacting with the AI, we're not talking to each other anymore. That's the dystopian view of like, well, AI is going to come gobble all of our careers. But I think there will be a readjustment of, we can think at a higher level because we're no longer spending evenings typing late into the night. And can we be freed up to be, oh, that's interesting, we're spotting some patterns here. I have time to think about pattern spotting rather than just completing things. So I don't know, right? In 2009, if you had asked us, what do you think the next evolution of phones would be? Well, like smarter chiclets on the bottom of the keyboard, and then Steve Jobs announces the iPhone and everything changes. I think there are inflection points that are coming that it's very difficult to see around the corner. Who knew that when ChatGPT, I think GPT-1 was, we would ask it to summarize things and it would just do a terrible job. But as we fed it more and more data out of this emergent property, it gets good at being able to respond to your questions. What? So I don't know, right? You can look maybe 6 months ahead, a year ahead, but I think more than a year ahead, it's very difficult to predict what's coming. And the point is, read, watch the news, try a tool here or there, see what you're thinking. When patients come in and say, well, my AI doesn't agree with you, you would say, well, actually, I tried that myself and I agree with you, except yours has a hallucination and this is why, right? You should have that sort of sophistication to be able to be confident so that when patients bring you something, you've tried it yourself. I would strongly encourage that. A couple of questions in the middle.
Hi, this is a little bit of a question, but also just kind of something I think to share with everybody about some opportunities with using AI to help kind of make our work more effective. Is some of these ambient note features with a bridge, you can actually upload, for example, a transcript of a trainee or a student into Copilot and ask Copilot to help you structure your feedback for the student or the trainee about their history taking skills. And so I think, we obviously do a lot of teaching in an ambient environment that's not the clinic, right? It's in the operating room. But I think that, talking to people, thinking about how the tools that are already accessible and HIPAA compliant for us, how we can use that to help accelerate some of our other, academic activities in terms of like teaching, effectiveness of feedback, self-assessment or evaluation for the trainees who are in here, right? Like these are all opportunities as well to use the tools we already have.
100%, thank you. In fact, I'll tell two brief vignettes. One is that I have a foundation student work with me, a second-year student start with me every year. And when they show up and they go, oh, you're the CMIO? So show me all the tools we're going to be using. I go, you're going to take out Microsoft Word and a blank piece of paper. You're going to write me a progress note with no help. Bottom to top, no abbreviations. Explain to me how you know what all the abbreviations mean. Like, oh, really? And actually, after one or two of these, they say, well, I actually prefer that. It forces me to think. I'm learning a lot more from these than I am if I just jump into a template, or worse yet, have the AI write the note for me. I'm really not learning in that case. So I think there are some interesting ways of dividing how you're working with students so they have productive cognitive friction on their way to writing a good note and learning those habits. At the same time, though, you're right, we can design prompts for our AI like Copilot and say, here's the transcript of the conversation, not only write a progress note, or even don't write me a progress note, critique the student's interview style, critique the differential diagnosis and see what opportunities there are, critique what was not gathered in the HPI that should have been given the patient's chief complaint, and you can get some really interesting data out of that. So we ought to be thinking about this as an additional entity, perhaps a smart medical student, a smart intern, and being able to use that as another way of thinking about learners.
What about AI and assisting with medical research? Is CU or UC Health looking at that? And what tools are available, or what do you see on the horizon?
Thanks for the question about research. I am sure, I have no idea the depth of investment that our researchers are using in the AI space, certainly starting with Copilot and so forth. I know that CU just invested in a partnership with OpenAI, for example, and then there's a number of tools where they're applying this to large data sets to try to get insights out of them, but I'm not totally close to those projects yet. Other questions? Please.
You touched on consent for a bridge. Any suggestions for when patients say no?
Yeah, so the question is about patients declining the recording. I would say, in my experience, it's maybe 1 in 100 that a patient will say, actually, I'm not comfortable, please don't turn that on. And then I'm sitting there going, how do I reactivate my Dragon license and do the regular recording, through speech recognition, or God forbid, I'm having to type it. And so I'm highly motivated when, a bridge is like stuttering. I'm like, wait, I want to make sure this is working before I work in the room. And so, yes, I think there will be a small fraction of patients who will decline it. But I think choosing your words carefully, I think in the beginning I used to say, I have a generative AI tool that will have a temporary recording that will be deleted in 30 days. Don't worry. Would it be okay? I'm like, I don't think I want my voice on there. What are you doing with that? And then now when I say I have an AI scribe that will help me write the notes today. In fact, what's even better than that is to say, if you wait a minute after our visit, I will show you a copy of it. You can take it home with you, right? And like, oh, I get a copy? Well, fine, that's fine. So that can be helpful to say, I'm going to be totally transparent and give you a copy of what it generates. But it's going to save me a lot of time. And most people, oh, I didn't realize that's how it's working for you. Oh, it's going to be deleted? Yes, nothing is retained. So the current setting is at 30 days, all recordings and transcripts are deleted. The legal medical record is the final progress note. And so focus your effort there. Nothing else is retained. And that's something that can be reassuring to patients. Please.
Hi, it's Jenny Ann. How are you?
Hi, Jenny.
I was going to ask if you could tell us, the clinicians in the room, how they can get involved to become maybe early testers or get early access to some of these tools.
Dr. Yee is always correct. We have 2 programs. We have a physician builder program with Epic. Those of you who like tinkering, who maybe have a computer science background or just interested in playing with technology, come talk to us, Dr. Yee or myself. And we have a physician builder program where, with training through Epic, we can actually grant you more sophisticated design tools inside the Epic electronic health record. Secondly, if programming is not your thing, then Smart User is a series of, I believe it's 10 one-hour webinars that you can take on your own time. That does give CME credit. And at the end of that, when you certify, we certify you as a smart user. We have about 300 people in our smart user community, and they all have early access to the AI tools. So as we get chart summarization, guess who? Those 300 people will get chart summarization first. So if you're a bleeding edge kind of person, please come join us on the smart user team, and Dr. Yee and I can certainly talk to you about it. Great. Thanks for the reminder, Dr. Yee. Thank you very much.
Thank you so much for a very. Thank you.
Thank you.